Hi, my name's Nicholas Crimes. I'm an anaesthetist in Melbourne, Australia. This is a short video to demonstrate the use of the Vortex for management of the unanticipated difficult airway in clinical practice. It's a recreation with actors, but it was done in a single take in real time. The setting is the emergency department, where a team of emergency doctors and nurses are preparing to intubate a patient with deteriorating conscious state. They've assessed the airway as being normal, and there's no expectation that there's going to be any difficulties with intubation.
Alright, so we're going to intubate this guy for decreased conscious state, and his SATs are a bit low. So Brooke, I'll get you to be my airway assistant. Yep. Nick, can you do drugs for me? Indy, I'll get you to do cricoid. Herman, if you can scribe for us. Jen, if you can just hang around in case we need you to go and get any extra equipment. Nick, I'll give you the Vortex so we can tick off things as we go.
Do you want to do a bit of planning?
Yeah, so let's plan what we're doing. So Brooke, for the first attempt, we'll have a size 3 blade, size 8 tube with an introducer. If that doesn't work, then what I want is a bougie and a McCoy blade. So if that fails, then we'll go on to face mask ventilation. So I'll get you to have a couple of differently sized masks for me. You've got Goodell's there, nasopharyngeals, good. And if that doesn't work, then I'll want to move to LMA, and I'll just want a classic LMA. Okay, if you can get that handy. Alright, everyone happy to go? Everyone knows what we're doing? Alright, so I'll get you to give some
drugs in?
Yeah.
Okay, so that's 150 of propofol going in.
Yep.
And 100 of sucks.
Yep. Okay, cricoid's on. Okay. Patients circulating. Let's have a look. Alright, so I've got a grade 3 view. All I can see is epiglottis. Just get you to take the cricoid off, Andy. Okay, give me a hand. Let's see if I can manipulate that larynx. Okay, that's not working, so I'll get rid of that.
You get a bit of call out, an optimal attempt to
please.
Okay, I'll go through the strategies. Okay, so manipulations of the head and neck, position.
Sniffing position.
Manipulations of the larynx.
Didn't work, taking it off.
Manipulations of the device, not relevant.
Yep.
Any adjuncts to intubation?
So can you grab that bougie handy for the next one, Brooke?
I want to change the size or type.
Yeah, and I'll grab that McCoy blade instead.
Suction going to help you?
No, nothing.
Pharyngeal muscle tone?
Happy that he's relaxed.
Okay.
Alright, that's working.
So this will be your optimal attempt at laryngoscopy?
Yep, absolutely. Alright. So still not getting a great view. Have we got a video laryngoscope handy, Brooke?
No, it's in Bino, but broke last week.
Okay, I'm just going to try and have a blind attempt here. It should feed that tube on for me. Okay, you hold on to the bougie. Alright. I'll just turn that a little bit for me. Manipulate that. Not very happy that that's in, but let's have a try ventilating.
That's that maybe 3 minutes.
Okay, just try and ventilate. So we're not getting rise and fall of the chest, we're not getting any titles, so let's take that out. So I'm happy to pull that.
We can't improve anything there, so that's an optimal attempt. ETT is over. So moving to face mask now.
Face mask.
Okay, strategies again. Head and neck, you've already said, is well positioned.
Yep.
Larynx, you've already taken cricoid off.
Yep.
Manipulate the device, you've already got 2 hands on. Any airway adjuncts, you've already got an oropharyngeal.
Yep.
Do you want to add a nasopharyngeal?
Yeah, that'd be good actually. Yep. You can grab that for me. Great.
Change the size or type of anything.
No, mask is good.
Suction going to help you.
No.
And you've already said they're well relaxed.
Absolutely. Okay. We've got some rise and fall of the chest there. I'm getting some blips of CO2. Okay, and SATs are now mid-80s. Alright, so I think we can try, we're not very happy with that, so we should go on to an LMA.
Well, hang on. We're in the green zone now. Do you want to have a think about Milan or?
SATs coming up.
Yeah, that's true. Alright, so let's just think where we're at. So we've got an airway and we're delivering oxygen at the moment. And if I do anything more, then we may actually lose everything. So let's have the LMA handy in case this fails. Okay, so Jen, can I get you to go and call the anaesthetist on call and get him to come down now? And also, Brooke, I'll get you to open up the surgical airway equipment and have that ready to go.
And I won't give any more drugs because if he starts to recover,
we'll let him. Yep.
And if that airway, which looks a bit precarious, but if it goes, we'll have about the LMA and we've lost nothing by waiting there. But if we put the LMA in first, we might traumatise him.
Yeah, absolutely.
Okay. So we'll hold on as long as we can get
Yeah.
anaesthetics.
Okay.
So the sequence through the Vortex pathway that these clinicians have opted to use has been to start with an endotracheal tube, to have an optimal attempt at that over several tries, to then proceed to an optimal attempt at face mask ventilation, and then to LMA. If all those had failed, they would have needed to proceed to a surgical airway. And they determined this during the planning phase before they even initiated inducing the patient. It's worth noting that the first attempt at face mask ventilation happens between the first and second attempts at intubation, whilst the optimisation strategies for endotracheal intubation are being discussed. Thus, each individual tried a non-surgical airway technique doesn't necessarily need to be had consecutively. As illustrated in the video, it's quite reasonable that after the first try at intubating the patient, a first attempt at face mask ventilation can be had whilst preparations to optimise the second try at intubation are being made. This makes for the most efficient use of time and is consistent with the way most critical care physicians practice. Therefore, the Vortex approach does not preclude the airway operator from initiating a first try at a rescue non-surgical airway technique before they've completed an optimal attempt at their preferred technique for non-surgical airway. As is demonstrated in the video though, whilst individual tries constituting an optimal attempt at any non-surgical airway technique may not happen in a strict linear sequence, the Vortex approach allows the team to track their progress through each of the non-surgical airway techniques and ensure that any relevant optimisation strategies are put in place. In the scenario portrayed in the video, we see that after an optimal attempt at intubation that is unsuccessful, implementation of optimisation strategies for face mask ventilation achieve a patent airway and alveolar oxygen delivery. Having recognised they're in the green zone, the team has the opportunity to optimise the oxygen saturations, mobilise resources, and make a plan before undertaking further interventions which might compromise their already tenuous airway. The plan is to make sure that the team is in the best possible position to succeed before proceeding any further. At the same time, preparations are made for an optimal attempt with a laryngeal mask airway in the event that their hand is forced by the face mask airway becoming obstructed and the ability to deliver oxygen to the alveoli being lost. The team is also well prepared to proceed to an emergency surgical airway if this is unsuccessful, both in terms of equipment readiness and in terms of their psychological preparedness, having already recognised that that's the next step if an optimal attempt with a laryngeal mask airway is unsuccessful. In this way, a balance is struck. The team adopts an approach which minimises the chance of them losing the patent airway they've already been able to achieve with a face mask, which could happen by performing further unnecessary airway interventions. At the same time, they plan their next step for what they will do if airway patency is lost before they're able to mobilise their resources. I hope this video has been useful to allow you to see more clearly how the Vortex approach might be employed in a real airway crisis situation. The scenario you've just watched illustrates how the Vortex approach can be used to facilitate getting a patent airway by a non-surgical airway, and potentially avoid the need to progress to an emergency surgical airway. Next week we'll put up a video demonstrating how the Vortex approach can be used in a different situation, that of an elective anaesthetic case occurring in an operating theatre. This video will illustrate how the Vortex approach can facilitate the team's progression through to an emergency surgical airway when optimal attempts at each of the 3 non-surgical techniques have failed and there's no other way to restore alveolar oxygen delivery.